Today we are going to discuss about the diseases of the salivary glands. So basically what is the anatomy? The major salivary glands you all know, that is parotid, submandibular and the sublingual, and the minor glands, they are distributed throughout the oral cavity within the mucosa and the submucosa. And the basic unit they contain is the acini, excretory duct and collecting duct. So what is the location of all these glands? The parotid gland is the largest salivary gland, lies between the sternocleidomastoid and the mandible, and it is divided by the facial nerve into the superficial and the deep part. The submandibular gland that lie inferior to the mandible in the submandibular triangle, and it is indented by the posterior border of the mylohyoid muscle into the superficial and the deep lobes. And the sublingual glands, they lie at the interior part of the floor of the mouth between the mucous membrane, mylohyoid muscle and the body of the mandible. So this is a picture showing the division of the parotid gland into the superficial and the deep part by the facial nerve. Then what is the inflammatory part? We will discuss about firstly the inflammatory condition. First is the parotitis. What is parotitis? It is basically acute non-suppurative viral parotitis that is caused by the mumps virus. Other virus can be involved like Coxsackie and cytomegalo, but the most common is the paramyxovirus. So secondary parotitis can occur due to duct obstruction, and usually this virus is spread by the droplet infection. This is a picture showing the acute parotitis. There is a lump seen in the inferior this parotid gland region. This is the lump showing. So what are the clinical features? The prodromal symptoms like fever, headache, myalgia, anorexia, arthralgia can be there, but the pain is very severe and it is made worse on eating, especially the citrus type of food. Then bilateral parotid swelling may be present in 75% of the cases. The gland is tender and trismus can be present, like swelling due to spasm of the muscle. Other gland, they also enlarges in 1 to 5 days. So what are the investigations? We will go for CBC, then radiology and silography. So what is the treatment? Conservative, rest, oral hygiene, good nutrition and plenty of fluids. Analgesia, local heat application to the gland can be given. Then adrenaline local application to reduce the duct edema. Antibiotic like clindamycin. Vaccination can be done at the age of 12 months. And if the patient develops abscess, we have to go for the drainage. Next, the complications can occur due to mumps because virus is the paramyxovirus. Aseptic meningitis, pancreatitis, nephritis, orchitis or ophiritis, and sensory hearing loss can be there due to this parotitis. Next inflammatory condition is the silolith. What is this? This is formation of calculi in the ductal system of the salivary gland, and the submandibular gland, that is basically mixed seromucinous gland, and its saliva has got high calcium and magnesium content, but as compared to the submandibular, the parotid is serous and it has got the low calcium and the magnesium content. So there are more chances of silolith formation in the submandibular gland. So what we will see, the stones we will see, they are radio opaque and cause is unknown. Salivary stasis can be there, ductal inflammation or ductal injury. What are the clinical features in cases of silolith? There is postprandial salivary colic with pain and swelling on the submandibular region due to duct obstruction can be there. Duct opening can be edematous or pouting, and stone can be palpated in the duct or within the gland on bimanual palpation. This is a picture showing the stone in the submandibular duct, and the gland is inflamed. And this is the stone in the duct that opens in the floor of the mouth, and it can be palpated by the bimanual palpation. This is the swelling, external swelling, and duct stone is seen in the floor of the mouth. So what are the investigations? Plain X-ray done to see the radiopaque stone, scilogram can be done, ultrasonography, CT and MRI. So stone, this is the stone seen on the CT scan. This is on the scilogram. So treatment is scilogram therapeutically washes stone, but finish each meal with the citrus drink, massage the gland. We can go for per-oral removal of calculi, marsupialization of duct can be done. Then if the gland is inflamed, we can remove the submandibular salivary gland. Per-oral removal is done. of the salivary calculi, and this is a specimen of the stone. Next is the Sjogren's syndrome. This is chronic autoimmune disease of the exocrine glands. It can be primary or secondary. Primary is when it is confined to the exocrine gland only. Features will be xerostomia and xerophthalmia, and secondary can be when this is associated with the autoimmune disease like the rheumatoid or the SLE, that is systemic leukemia erythematosus. Clinical features, because it is a multi-system disease, so there is dryness of mouth, eyes, difficulty in chewing or swallowing food due to xerostomia, intolerance to the acidic and the spicy food, then dental caries can be there, smooth and fissured tongue can be there, candidiasis, stomatitis. All these secondary complications are due to the basically xerostomia and the xerophthalmia. This is a picture showing the dry eyes, damage to the eye surface, dry mouth, increased teeth decay. Then in investigations, when we will see the ESR will be raised, the presence of HLA1 and B8 antigen will be there. Schirmer test, when there is wetting less than 5 mm in 5 minutes, this is done in the lower lid of the eye. Usually that gets wet, this strip paper that gets wet within 5 minutes, but in this case Sjogren's syndrome, the wetting is less than 5 mm in the 5 minutes. Salivary flow rate is also decreased, it is less than 0.5 ml. That helps to diagnose a xerostomia. Treatment is mainly the steroids. Symptomatic management can be done in the form of artificial tears, synthetic saliva can be given, bromhexin 40 mg per day for tenacious cough can be given. So treatment is, in cases of dry mouth, we can go for sprays or stimulants like hard candy, pilocarpine, cholinergic agents like cavimelin, special toothpaste, oral gel, active dental care can be done. Dry eyes, their lubricant eye drops, ointments, punctal plugs, lateral tarsorrhaphy. Then for dry nasal mucosa, we can go for saline nasal sprays and the lavage. Next is the salivary gland neoplasm. So what is the etiology? Increased risk is seen in cases of radiation exposure, a viral infection, genetic alterations, tobacco chewing, occupational exposure to silica dust, rubber workers, nickel, this compound, alloy or hair dye, kerosene or vegetable preserved in the salt. Decreased risk is seen in cases of high intake of liver, high intake of dark yellow vegetables. So what are the investigations we will go for salivary gland tumors? The laboratory tests are CBC, then RBS, thyroid function test, anti-nuclear antibody, RA factor. Radiological test is ultrasonography, neoplasm, they appear solid and provide guidance in obtaining the FNAC. CT scan is gold standard, and administration of contrast that provides details of the tumor volume relation to the vascular and the bony structures, and irregular pattern is seen in cases of malignancy. On MRI scan, what we will see the excellent soft tissue details, doesn't require contrast. For vascular details, then positron emission tomography can be done, that is helpful in staging of the salivary malignancy to rule out the distant and the regional metastasis, and it is also helpful in follow-up patients. So this is the basically showing the tumor mass in the tail of the parotid gland with minimal thin peripheral enhancement that is consistent with the Warthin tumor. Then this is also the CT of the left parotid, that's showing the superficial involvement of the lobe. Then we can go for other investigation is FNAC, that is mainstay of diagnosis and management, safe, simple and inexpensive. If the tumor is obviously malignant and involving the skin, then we can go for the incisional biopsy. Then this pleomorphic adenoma, this is most common of all the salivary gland neoplasm. Usually seen in 4 to 6 decades, slow growing, painless mass, and usually seen in the superficial lobe, mostly in the tail of the parotid. And then on pathology, we will see the smooth, well demarcated, solid and cystic changes, and histology, we will see the mixture of epithelial, myoepithelial and stromal components. Treatment is superficial parotidectomy with facial nerve preservation. Next is the Warthin tumor. Synonym is the papillary cyst adenoma lymphomatosum, and it is basically 10% cases are bilateral and 3% with associated neoplasm. Presentation is slow growing, painless mass, ovoid shape situated in the tail of the parotid. On pathology, encapsulated smooth surface, cystic spaces of the variable size with viscous chocolate fluid or tubular epithelium is seen. So next is the mucoepidermoid carcinoma. In this, this is also most common salivary gland malignancy, and parotid is involved in 45 to 70% of the cases. Female are more involved than males, and the presentation is whether it is of low grade or high grade. Low grade is slow growing painless mass, reoccur locally, but high grade is rapidly enlarging, can be associated with pains, and it can metastasize to lymph nodes, lungs, bones, and brain. So what are the investigations? CT, MRI, FNAC. Avoid biopsy in cases of mucoepidermoid carcinoma because it can lead to the seedling with the neoplastic cells. So treatment is depending upon the stage. If it is of stage 1 and 2, we can go for wide local excision, but if stage 3 and 4, radical excision plus a neck dissection may be required, and radiotherapy. Next is the adenoid cystic carcinoma. Overall, second most common malignancy, most common in the submandibular and sublingual and the minor salivary glands. Presentation is asymptomatic, enlarging mass, pain, paresthesia can occur, facial weakness, and on pathology we will see the characteristic, the Swiss cheese appearance of the tumor or cribriform pattern. Treatment is complete local excision, tendency for perineural invasion, especially the facial nerve can be involved, so facial nerve sacrifice have to be done, then post-operative radiotherapy can be given. Next is the acinic cell carcinoma. This is second most common parotid and pediatric malignancy, and usually seen in the 5th decade. For females are more involved than the males. Then presentation is solitary, slow growing, often painless mass, and on histology we will see the basophilic granular cytoplasm, small dark eccentric nuclei, and treatment is complete local excision plus we can add the radiotherapy. Prognosis is fairly good. 5-year survival rate is 82%. Then is the adenocarcinoma, that is rare, and in this the main gland involved is the parotid. Presentation is enlarging mass, and 25% patients they are associated with pain or the facial weakness. Treatment is complete local excision and the neck dissection plus chemoradiation. Thank you.